the faculty and Simone from Sharsheret, which is a truly wonderful organization, were able to come together. We are incredibly grateful. And we know that if this session leads to one person getting an answer that might very well contribute to their good health or even save their life, this will be completely worth it. Right? We are a Jewish tradition that believes you save one life, you save the entire world. And so thank you to everybody who is here, and know that even though the sanctuary is not overflowing tonight, that you have the potential to do great good. I was invited to just open the session. I'll be very brief, but I wanted to dedicate this learning tonight in honor of two women who our community lost both to ovarian cancer last year. Within 6 weeks of one another, two women, both in their 50s, both with teenage daughters, two teenage daughters, both passed away after each a 7-year fight with ovarian cancer. Ida Kelly and Nikki Gurek, very dear to many people in this room. It was an extraordinary confluence that their stories were so similar and their timelines and their passing were so similar. And both of their passings have left great holes in our community. And it's heartening to know that the research continues, that the technology continues, that the medical breakthroughs continue to make it more and more likely that there will be less and less of stories like the story of Ida and the story of Nikki. And so in their memory, I want to dedicate this session with gratitude to the healthcare professionals, the doctors, and the nurses, and all of the people who play supportive roles, who help people walk through this incredibly difficult road, and with hopes that the world that we will pass on to Nikki's daughters and to Ida's daughters will be safer and healthier for them than it was for their moms. And so with their spirits here present with us, and with great gratitude, I'm excited to turn this over to Simone from Sharsheret. Sharsheret is an organization I have admired for many years. Actually, my wife's former roommate, Jenna, was a Sharsheret organizer in Los Angeles for many years, so I've been aware of it. When I ran the mikveh at American Jewish University, we had a partnership with Sharsheret, with people coming to the mikveh after breast surgery, after reconstruction, after cancer treatments, and we're able to welcome in many women who were trying to open up a new chapter in their lives after this traumatic moment. So I've been aware of your work for a very long time, and I'm very, very grateful to have you here in our house. So Simone, please share a little bit more.
Thank you so much, Rabbi Greenwald. Really, really appreciate your warm welcome. I want to thank everyone for joining us on this Monday evening to learn about cancer screening, survivorship, and tools to optimize your quality of life. Before we begin, I want to thank our generous sponsors. The City of Hope, we received a City of Hope Kindness Grant, which is allowing us to put on this program. This is the third in a 3-part series called the Orange County Jewish Cancer Initiative, geared toward educating the Orange County community about cancer prevention, treatment, and genetics. I want to thank Congregation B'nai Israel, the Community Scholars Program, and Ari Katz, and the Mirage JCC for their partnership. And I specifically want to thank Rabbi Greenwald and Sam Brown and the CBI community for hosting this third and final event in this educational series. We also want to thank Merck for their generous sponsorship of Sharsheret community programs, and the many Orange County area synagogues who promoted this event within their communities. This event is also part of the Sharsheret Summit, and we are thankful for all of our summit sponsors and partners who can be found on our summit website at summit.sharsheret.org. I'm a social worker for Sharsheret, and I'm so happy to be here this evening to introduce this program on cancer screening to survivorship, because Orange County has been my home for the past 29 years. And I'm very eager to bring awareness of Sharsheret, this great resource, to our community. Sharsheret is the Hebrew word for chain or connection, and the organization's name comes from the belief in the importance of these connections, that we are all links in a chain supporting one another. Sharsheret is a national nonprofit organization started by Rochelle Shoretz, a young Jewish mother from New Jersey, who was diagnosed with breast cancer at the age of 28. When Rochelle was diagnosed, all she wanted was to connect with someone like her who was going through what she was going through. Friends introduced her to another young Jewish mom who was a few months ahead in her breast cancer treatment. They were the first links in the chain of support, and that's how Sharsheret was born, around Rochelle's kitchen table. Next month, we will celebrate our 22nd anniversary with offices in New Jersey, New York, Illinois, Florida, and California, and a staff of almost 40, including social workers, a genetic counselor, and outreach professionals. Since our founding, Sharsheret has connected with close to 250,000 women, families, healthcare, and other professionals, as well as students on college and high school campuses. At Sharsheret, we specialize in the unique needs of the Jewish community, but we support everyone, regardless of background, race, gender, sexual orientation, age, or religion. Our support services are all virtual and are designed to help navigate you through the cancer experience. We provide free and confidential genetic and mental health counseling, emotional support, financial subsidies for non-medical needs like custom real hair wigs or eyebrow tattooing, and life-saving education. While we provide support to people of all backgrounds, one of the things that makes Sharsheret so relevant at this time of great tragedy in our Jewish community is our ability to support those in our community who are not only dealing with a cancer diagnosis, but also with the added layer of grief and fear as Jews who are experiencing a collective trauma and who have direct connections to relatives and loved ones in Israel. We are uniquely positioned to be able to provide the kind of support that Jewish cancer patients need during this time, because we understand the mix of emotions that Jewish families are experiencing right now. As we move into the program itself, I'd like to remind you that the information provided by Sharsheret is not a substitute for medical advice or treatment for specific medical conditions. You should not use this information to diagnose or treat a health problem. If you have any questions that are specific to your medical care, we recommend that you speak directly to your medical provider. We are going to be hearing from some incredible speakers this evening who will discuss not only screening for cancers, but also tools to optimize quality of life for survivors of cancer. I'm honored to introduce our esteemed speakers, which include 4 doctors from the City of Hope in Orange County: Dr. Joshua Cohen, Dr. Seth Cohen, Dr. Jessica Chang, and Dr. Jennifer Sang. Please hold your questions to the end after all the speakers have presented, when we will have a Q&A period. So I'm gonna just go through the bios for each of the doctors. We kind of have just a smaller version of their bios because they all have wonderful records and lots of things to share. But if you're interested in seeing their full bio, we have a flyer out on the table in the front, and you can look at their full bios there. Dr. Jennifer Sang is a double board certified surgical oncologist, and she firmly believes in shared decision-making between physicians and patients. She is a strong patient advocate and sets high standards of care, continually striving for improvement and meticulously planning surgeries to provide patients with the best possible outcomes. Dr. Sang is a native of Southern California, having grown up in Orange County, California. Dr. Sang has expertise in addressing cancers of the breast, skin, and soft tissue. As medical director of breast surgery at City of Hope, Orange County, she is committed to offering patients a slate of innovative clinical trials. As a researcher, she has co-authored over 100 peer-reviewed publications, review articles, book chapters, and abstracts. Dr. Sang is extremely happy to return to the place she considers home and serve the local community. Dr. Josh Cohen is a board-certified gynecologic oncologist and medical director of the Gynecologic Cancer Program at the Lennar Foundation Cancer Center at City of Hope, Orange County. He is an expert in the surgical cytoreduction of cancer and in the use of minimally invasive surgical techniques, including robotic surgery. He completed a fellowship in gynecologic oncology at UCLA and Cedars-Sinai Medical Center. He has been recognized by Los Angeles Magazine as one of LA's top doctors and a Southern California super doctor. Dr. Cohen grew up in Orange County as well and is a member of Congregation B'nai Israel. And he considers it an honor to serve patients in the same area where he was raised. He has worked with Sharsheret for the past 5 years, joining our California Advisory Committee this year, and is grateful for the immense work that Sharsheret continues to do with patients and families impacted by breast and ovarian cancer. And we are very grateful to have you on our advisory board as well. Dr. Jessica Chang is among the nation's few and Orange County's only fellowship-trained experts in cancer rehabilitation medicine. This is a subspecialty of physical medicine and rehabilitation, also known as physiatry. Did I say that right? Yeah. Okay. She has expertise in optimizing function and independence for people with cancer throughout all stages of the journey, with a special focus on musculoskeletal and neurological conditions. Dr. Chang partners with each person to help people prepare for cancer treatment and to get back to doing what's important to them. Her goal is to help people live their best life at school, work, or home, in the community, or for recreation. At City of Hope, Dr. Chang creates comprehensive rehabilitation plans for each patient with a body, mind, spirit approach. She collaborates closely with oncologic teams, medical specialties, and other supportive and integrative services to ensure care plans that are cohesive, feasible, and meaningful. And our final doctor who's going to be presenting tonight is Dr. Seth Cohen, who bears a very close resemblance to his brother, Dr. Josh Cohen. Dr. Seth Cohen is a urologist specializing in urogynecology and female urology. His practice focuses on pelvic floor challenges and optimizing quality of life for patients. He leads the survivorship program at City of Hope, Orange County, and is also director of the City of Hope Fellowship in Reconstructive Urology and Genitourinary Cancer Survivorship Fellowship, focused on providing physicians 1 year of training in pelvic floor care. So without further ado, I would like to turn it over to Dr. Jennifer Sang, who will get us started. Thank you.
Oh, thank you for the kind introduction to all of us. Hi, good evening, everyone. I'm Jennifer Sang. I'm just trying to... You're seeing the screen move, correct? Okay, I can't see it. So a lot of you may be aware October is Breast Cancer Awareness Month, so I'm very pleased to be able to kick off the sessions tonight by talking a little bit about breast cancer. And I wanted to focus on screening since it's Breast Cancer Awareness Month, and I'm a surgeon, so I thought I'd highlight a couple surgical things as well. So let's start off with screening. So some of you may know the stats are that 1 in 8 women in the United States will develop breast cancer at some point in their life. But in Orange County, it's actually 1 in 7. So this is a disease that we at City of Hope hope to continue to raise awareness about. So firstly, what are some symptoms to pay attention to? These are ones that you may be watching in yourself, or this could be information that you're going to share with loved ones after tonight too. But we're always asking patients to pay attention to if they notice anything different than usual. So this is a whole constellation of symptoms that's hard to always remember. Watch for this, watch for that. I just say if something is different, please come in. And the something different oftentimes we think about is maybe a lump that you feel on your breast, but you also might feel that there's skin or other areas that are pulling at you. Or otherwise you might have new pain, especially if you're feeling lumps and bumps under the armpit. These are common reasons why patients come in and seek evaluation. And not all of these symptoms are breast cancer. Oftentimes they can be benign different changes that are happening with somebody's health, but these can be the first tip-off that breast cancer is there. So if you don't have symptoms, though, we really emphasize imaging screening. So who, what, when, and how should we think about this? So who, first of all? So I like things that are easier to remember. So I talk about the number 40 a lot. So if you have no family history, no increased risk, please, as a woman, start screening at age 40. And that usually entails getting annual once-a-year mammograms. Mammography can lower the risk of dying of breast cancer by 40%, 40 again. And the most lives are saved by yearly mammography starting at age 40. So that is the year that we really recommend that someone go in for their first breast imaging exam. However, a lot of us may be at higher risk for breast cancer because we have a family history or other things in our health that may increase our risk above that 1 in 7 in the population. That could be loved ones with a history of breast cancer. It could be being Ashkenazi Jewish. It could be being of higher BMI or having increased estrogen use over the course of one's lifetime. Some of these are like fertility treatments, long-standing usage of oral contraceptives. These are aspects of somebody's life history that may increase their risk. Also, some of the more unusual things that unfortunately we do see in the population is a childhood or young adult risk because of increased exposure to radiation for treatment or other reasons, or maybe having an atypical diagnosis after an imaging finding at some point. So someone who's of higher risk, we actually don't just recommend starting screening at age 40. They may be eligible to start imaging even as young as 25. And you may think back to when you were 25, if you're older than 25, and think, did I even have a primary care physician, right? So these are things that we really need to emphasize, get disseminated in the community, because unfortunately we're seeing breast cancer younger and younger. I am seeing patients in their 20s, their 30s. I saw a 19-year-old the other day too, okay? These patients often will have a higher lifetime risk when you probe into their family history. And I have to admit, as a 25-year-old, I didn't know my own family history that well, right? And so these are things that we can encourage in our loved ones for them to gather information on family. And so some of the reasons for increased lifetime risk, in addition to what I mentioned, is someone having a genetic mutation. So most common that we think about are the BRCA1 or 2 mutations. So women like Angelina Jolie, she has a BRCA mutation. And so that's a lot of times these celebrities have started to raise awareness. And a genetic mutation is something that you have to get tested for. So you have to know that you're potentially at risk to be able to seek care, to get testing, to understand more about your health and what your lifetime screening should be. So what is breast cancer screening? So a lot of you may have heard of mammograms. They're x-rays of the breast. And so x-rays of the breast, the reports come out, and there's a designation from 0 to 6 as to how concerning something is to be breast cancer if there's a finding on the examination. One of the newer aspects is California is a mandatory reporting state where breast density, how much white instead of black you have on an x-ray, must be reported out in your mammography report from the radiologist. And we know that increased density can actually be a risk factor for breast cancer as well, and that's why it's mandatory reporting in 26 out of 50 states. So mammography, also we think about traditional 2D views, but most of the time, especially at City of Hope, we actually encourage 3D views because then it can actually capture different aspects of the breast and find breast cancers in a more detailed way. Those who are higher risk of breast cancer, they actually may be recommended for one additional exam. It's called a breast MRI. It's in the magnet field, no radiation, but you do need a contrast agent called gadolinium. And you're in this unusual position of being on your stomach for this exam. So I always tell patients, you're going to be imaged in every different position. X-rays, you're upright. Ultrasound, you're on your back. And then for the MRI, you're on your stomach. Just to change up all the views, we can look at your breast and be very, very comprehensive. But you can see that we get actually very detailed views of the breast this way on MRI. So when? So back to this number 40. 40 is the key number. But if you're at higher risk, you may start at age 25, as I was mentioning. But you should definitely start 10 years below the youngest age of your family member. So if the youngest age of a first-degree relative was they developed breast cancer at 42, you should start at 32. And the earliest age to start mammograms is 30, but you would start MRIs earlier, starting at 25, if you have a younger family member who was at risk. So for high risk, we recommend this annual triple imaging, mammography, ultrasound, and MRIs, and a once a year clinical exam by someone experienced. So that could be myself as a breast surgeon, it could be an OBGYN, it could be a primary care physician. But a lot of you may know when you go to your primary care as a woman, they don't always do a breast exam. So you have to find a provider who's good at it, who's reliable at it. And how to reduce risk. That's one of the things we always talk about in linking it with screening. So we talk about risk reduction, so getting some activity in, 30 minutes a day. And that may not be exercise, that may just be getting your heart rate up by gardening, by walking the dog, by doing something with activity is very important. We also really recommend reduction of alcohol intake. The latest guidelines for breast cancer survivors is really no alcohol. For those who are at risk, we moderate that down to about 1 to 2 drinks a week. And then definitely some of the lifestyle factors that we know is not great for our health, like smoking, can actually be something that increases risk of breast cancer as well. Some women who are higher risk may want to take risk-reducing medication, which are called hormone blockers or endocrine therapy. This is something I won't spend a lot of time on, but there are different medical ways that we can reduce risk of breast cancer as well. And some women think about surgery, so this is my territory. Those at really high risk for breast cancer, the BRCA1 and 2 mutations, have up to an 80% lifetime risk of developing breast cancer. So a lot of you may know women who have undergone prophylactic or preventative surgery. A lot of women seek this out to be very proactive, and it's a really nuanced conversation. A BRCA mutation does not equal having to have surgery. It's not a direct linkage, but a lot of women do think about it. So who? Women. What? We should think about annual mammograms starting at age 40 and maybe earlier at age 25. And then how is to reduce our risk is lifetime counseling, risk-reducing medication, and maybe prophylactic surgery for the right population. So what does surgery entail? So we think about surgery for treatment of breast cancer in these two traditional ways. Do we save part of the breast and remove the cancer, or take out the whole breast to remove the breast cancer? So usually in the past, we'd make a scar on the breast to take out a smaller cancer, or maybe take out the whole breast and leave a line across the chest wall so someone could have a bra insert called a prosthetic placed over it. So under clothing, you can't really tell any difference. But we've made some advances since this. We still do these two surgeries all the time, but we often incorporate a couple new techniques. Some of you may have heard of. Some of you, this may be new. So we think about a concept called oncoplasty, where when we remove part of a breast, we may be able to do that through a more cosmetically appealing way. Why this is important is that asymmetry is actually terrible for anybody. Your neck, your shoulders feel the imbalance when you're not symmetric. And so we think about using appealing scars, hiding it in the armpit, on the underside of the breast, other ways where we don't cause so much deformity, or actually rearranging tissue so that things don't cave in or gap. And that's very important for bra fit, other things that are really crucial for quality of life. So we do cancer operations very safely this way, but also maintain good overall health, because a lot of you may know or may have heard of, for stage 1 and stage 2 breast cancers, 99% stay cancer-free at 5 years. We've got great statistics for this, so we need to emphasize quality of life in the long run too. So something new that we're pioneering here at City of Hope and across 14 other centers in the United States is using the robotic surgery device to take out the breast. So the conventional open scars, we use scars across the front side of the breast, but in robotic surgery, what we do is create an artificial working space with carbon dioxide gas, and we can use a much smaller scar on the side of the breast to remove the breast tissue from the chest wall. Why this is important is anytime we make a scar over the front of the breast, the blood supply doesn't love that. So there's at risk for the skin or the nipple to actually not make it and to die from the surgery. So when we place the incision on the side of the breast, we don't interfere with blood flow patterns. So currently we have a trial open through FDA guidance of comparing open surgery versus robotic surgery here at City of Hope to be able to study this. The surgery is offered in Europe and Asia already, so we're hoping that the US can be the next frontier where this can happen. Other things that are improvements over time is that we offer breast reconstruction, where women can have an implant placed right after we remove the breast, or even having tissue transferred into. These are aspects that are really crucial for women to feel good about their bodies and their figure, and just have great psychological, emotional well-being as well. For a lot of women, they need lymph nodes sampled, and sometimes some would need a very aggressive removal of lymph nodes in the armpit called the axilla. This can increase risk of a side effect called lymphedema or arm swelling. And so working with my plastic and reconstructive surgeons, we work in combination to dissect out very fine lymphatic drainage structures so that my plastic surgeon under a high-powered microscope can put that little drainage structure into a little blood vessel and reopen the collateralization. So when we do the surgery, it's like cut off plumbing pipes, and what I say is this lymphovenous bypass, it's like a reroute instead. And that can really help prevent this risk of arm swelling in the long run. So thank you for your attention, a little bit of a whirlwind through screening and surgery, and I'm happy to take questions later on. But I'm gonna introduce then Dr. Cohen.
Thank you all very much for coming tonight, Monday evening. I want to acknowledge, clearly the very sad and horrific events around the world, and just, I know our hearts and minds are in many other places, but want to also, I'm proud of you for taking a few minutes out of your evening to learn and hopefully get some information that might be important for you and your family, or for loved ones that you care for. So September was Gynecologic Cancer Awareness Month. Obviously October is Breast Cancer Awareness Month. It's our opportunity to really help get the word out about these cancers. Sadly, about 100,000 women in the U.S. will be diagnosed with a gynecologic cancer this year. When I say gynecologic cancer, that includes ovarian cancer, uterine cancer or endometrial cancer, vulvar cancer, vaginal cancer, and cervical cancer. And sadly, 30,000 women will die in the U.S. because of one of these cancers this year. Unlike breast cancer, and I love hearing those numbers, I love hearing 99% survival for stage 1 and 2, we just don't have that. Sadly, 80% of women with ovarian cancer diagnosed as stage 3 and 4. Survival is less than 50% in 5 years. We do not have good screening tools for this, and so what I'm here today to make a plea to you and to your loved ones is prevention and screening for genetic mutations, because that's how we're going to save lives. I can tell you every day I go to work, my goal is to cure patients with ovarian cancer, and we're getting better at it, but we're not there to the point where we can make a huge dent in that's 5-year survival. What I would say is know what's normal for you. Ovarian cancer symptoms are very nondescript: abdominal bloating, early satiety, nausea and vomiting, abnormal bleeding. These are things that on any given day you may experience one perhaps, but if you're experiencing this and it's persistent, talk to your OB/GYN, talk to your primary care doctor, seek out a specialist, get the word out, advocate for yourself. In the US, about 20,000 women will be diagnosed with ovarian cancer this year, and about 13,000 deaths. You can see this is a list of the cancer deaths for men and women in the US. Clearly, lung cancer is still the main driver, but ovarian cancer, although it's rare, is the 5th leading cause of cancer death for women in the US. Uterine cancer is actually the 6th leading cause. Uterine cancer is one of the few cancers where the incidence is going up. So 66,000 women this year will be diagnosed with uterine cancer in the US, and that number is going up and up. It's not going down, which can be a little scary for a cancer doctor, so we want to make that better. But this is our opportunity to do that. I'm Ashkenazi Jewish. My name's Josh Cohen, so that's, I guess, one of my disclosures. Many of you know my wife, Jackie. Jackie's aunt is BRCA1 positive. Her grandma, who passed away, is BRCA1 positive. Jackie's okay with me sharing that she is not BRCA1 positive. Her mom is negative, but clearly our family's been impacted by BRCA. When you go to synagogue on Saturday morning this weekend, if you look around the room, every 30 people, one of them will have BRCA in our population. So just so you know that. So every time you come and look around, if this room's full, there's going to at least be 5 to 6 people in this room who are going to have a BRCA mutation. So 1 in 40 Ashkenazi Jews, 1 in 500 in the general population, 40% of Jewish women with ovarian and fallopian tube cancer, and 20% have premenopausal breast cancer, as you heard from Dr. Singh. BRCA mutations can be passed down from mom or dad. So whether it's the dad who has BRCA or the mom, the child has a 50% chance of having that mutation. And that sometimes can be confusing. Sometimes I'll hear from patients, well, my mom was negative, so I'm okay, but if dad had it, then you're going to have a 50% chance of having it. And we don't often talk about what happened on the shtetl with Bubby and Zadie, years and years ago, right? We don't do that. We should do that more, what great-grandma and great-grandpa had. But we need to know what your family's history is. And if you have Ashkenazi Jewish background, you should have genetic testing because that 1 in 30 to 1 in 40 risk is too high. There is emerging data about Sephardic Jews as well. I know we're talking about Ashkenazi Jews, but not to make any of the Sephardic Jews in the audience feel left out. There is data that there is also an increased risk for this population as well. One of the reasons that we're here to get the word out in Orange County is that really no one should go undiagnosed with a BRCA mutation because it's a unique moment to prevent cancer. I will tell you one of the biggest forms of solace that my patients have with BRCA when they're dying is that they've probably saved the lives of some of their family members, because if they get tested and they're positive, they're going to help prevent their kids, their grandkids, their cousins from getting these cancers. I mentioned some of the symptoms, and I think really the take home here is know what's normal for you. A day of feeling bloated is not worrisome. A week or 2 weeks or 3 weeks and something feels off, that's not normal. I'm fairly new to Orange County. I grew up here, but we moved back not too long ago. It's hard to get primary care doctors. I'll be honest. I'm still looking for a primary care doctor. So just know that we're here for you too. You can always reach out to any of us through City of Hope. But I think you got to advocate for yourself. So even if you have a tough time getting in to see a primary care doctor, call your OBGYN, call someone, get tested, get an exam. Don't go saying, oh, this is nothing, it's going to go away. Because if you're worried, then we want to hear from you. We want to advocate for you. So just not to get too into the weeds of genetic testing, but there's more than just BRCA1 and 2. BRCA1 and 2 are the most common genes, especially in the Ashkenazi population. But we actually have up to about 40 different genes now that have a high risk of breast cancer and possibly ovarian cancer. City of Hope is offering free genetic testing for all of our patients, and the panel we use is about 120 genes now, meaning there's about 120 different genes that are actionable, that if you have a mutation from your mom or your dad in your DNA, we can actually take action to reduce your risk of cancer. I've been referred young women who've said, Dr. Cohen, I never want to have kids because I never want to pass on this mutation. And whatever your beliefs are in our world, we now have the technology for people to make embryos, and then we can tell them which embryos have these genes and which don't. So someone who's younger who does not want to pass on a BRCA mutation, but they want to have a child, they can actually do that with reproductive technology, and we can identify which embryo does have a BRCA mutation, which one does not. Again, completely up to what your beliefs are, but I believe every patient should be aware of this technology. There's a difference between germline and somatic. So germline is every cell in your body, meaning that from your parents you get one set of genes from your mom, one set from your dad. Every cell in your body has 50% of each of those. There's something called somatic mutations. Somatic mutations are what happen spontaneously in tumors that are formed with cancer. Most cancer is spontaneous, so 80% of cancers are somatic mutations that happen every moment of your life. Cells are dividing hundreds of thousands of times, and it's actually a miracle when you think about it that we don't have more of these spontaneous mutations. We have checks and balances in our body that recognize errors, and it doesn't proceed. Cancer is what happens when those errors don't go unchecked and they continue to grow. 80% of cancers are due to those quote-unquote somatic mutations. We have genetic counselors through City of Hope. Sharsheret has an amazing group of genetic counselors. We're lucky that we live in a world now with everybody so comfortable with telemedicine and video visits that whether you have family in a remote part of Alaska or family here in Santa Ana, California, everybody now has access to a genetic counselor, so take advantage of it. I would say some of the things that I would love my patients to know or want them to know if they're going through a new cancer diagnosis is to see someone like me, see a gynecologic oncologist, someone who focuses on gynecologic cancer, see someone like Dr. Singh who focuses on breast cancer. You should feel comfortable to ask about the treatment plan. It's okay to get a second opinion. Oftentimes when I talk to patients, it amazes me that they'll meet one person and they make a life-changing decision over that 20-minute visit with someone they've never met before, but then you talk to them about their car and they went to 5 different car dealerships to get 5 different offers. Doesn't quite make sense. Or if you buy a house, you're not, mortgage, you're going to get 3 or 4 different offers. But as patients, we don't know how to advocate for ourselves. So we walk into the doctor and we assume that doctor is giving, and they're giving their best opinion, but no, it's one opinion. And I would tell you here in Orange County, as someone who came back here to make a difference, you want to go to a comprehensive cancer center. You want to get an opinion from a place that treats cancer patients, pretty consistently. Local community hospitals mean well, but it means something when you're going to a place that specializes in what you're being treated for. So ovarian cancer, just to summarize here, we're almost done with these slides, is really a combination of surgery and chemotherapy. It's not one or the other. Really, these surgeries can be very big and involve surgeries. These are very long, complex surgeries. Patients often spend at least 3 to 7 nights in the hospital. We do have very good outcomes for patients, but it can be an ordeal. It's a journey. We do have clinical trials. So clinical trials, the next greatest advance for a lot of our patients. You heard about a robotic surgery trial for breast cancer, which is groundbreaking, and we're so lucky that Dr. Singh is doing that. We have a number of these trials for ovarian cancer involving heated chemotherapy in the abdominal cavity, CAR T-cell therapy, where we're using the body's own immune system to attack cancer cells. It's really a very exciting and gratifying time to be in cancer care because there are so many unique advances right now. We also have maintenance therapies once someone's done with their ovarian cancer treatment. There's a medication called a PARP inhibitor. It's curing people. This is something that's an oral pill designed for BRCA mutation carriers. So if my wife's side of the family, if someone had ovarian cancer, that pill alone may have cured them after their surgery and their chemotherapy. And we're seeing that now, which is so gratifying. And then we want to optimize quality of life. We live in Southern California, so I talk about Magic Johnson from the Lakers. Everybody knows Magic Johnson. So in 1991, when he was diagnosed with HIV and we all watched the TV and he said that, what did we all think? We said, this guy's going to die. He's got HIV. We've got nothing to offer him. What is he doing now? He's living a long, happy, healthy life because we made HIV chronic. You take your antiretrovirals, the viral load stays low, you live a long, happy, healthy life. We're not there yet with cancer, but we're getting much better. We're getting much better. And for those patients we can't cure, what I talked about is we walk that line. We do the cancer drugs. We keep the cancer at a low titer, a low disease burden, and you live your life. Life goes on. You spend time with the grandkids. You go out, you do family events, and that's time that's precious for all of us. So I talked a little bit about heated chemotherapy. We have new antibody drug conjugates where they're like smart bombs or Trojan war horses where we attack the cancer with basically these fake molecules that hide them. It's very exciting. Immunotherapy, CAR T-cell therapy. We actually can do pressurized gas-embedded chemotherapy directly into the abdomen in addition to the clinical trials. So with that, I'm going to close and just say a huge thank you to Sharsheret. I refer probably 4 to 5 patients a week to this organization. Orange County, although it's the 6th largest county in the country by population, has very little support for cancer patients, especially breast and ovarian cancer, in my opinion. And Sharsheret's one of the few organizations with us making strides, and we're so grateful for their efforts. I want to say thank you to Rabbi Greenwald for having us here, and Sam. CBI has a special place in our hearts, clearly. I really want this to be a place where we can make a dent and hopefully prevent patients from developing cancer in the first place. So with that, I'm going to invite Dr. Jessica Chang up, and she's going to talk about the other side of cancer care.
Thank you everyone for joining us tonight. Let me get used to this here. So I also want to thank Dr. Josh Cohen for sending me the most patients out of all surgeons at City of Hope, Orange County. Jen Sing's on the rise too, not to leave her out. Okay, so first, what is cancer rehabilitation? How many of you guys have heard this before? All right, I'm glad to be here. So first off, let's start with a definition. Cancer rehabilitation is truly a team sport. We aim to optimize function that's related to cancer or its treatment. So the core team of cancer rehabilitation is PM&R, PT, physical therapy, OT, occupational therapy, and speech therapy. I always like to start with just defining who I am. So PM&R stands for Physical Medicine and Rehabilitation. Another way to say it, it's also known as physiatry or physiatry. So she was right. It's one of two. Whichever one you want to say, they say physiatry because it sounds less like psychiatry. But these are all the same things, or rehab medicine. So background, physical medicine and rehab, PM&R is a specialty. And I did a one-year fellowship in focusing on cancer rehabilitation medicine specifically. All right, long introduction. Let's move on. So let's start with a poem. I asked ChatGPT for a poem on the soul of cancer rehabilitation, and I loved what it came up with. So, in halls of strength, we find our way, where hope ignites, where shadows sway. Cancer's challenge we boldly face. In rehab's grace, we find our place. With therapist guidance, we reclaim our strength and spirit, not the same. In every step, we heal and mend. Cancer's grip, we shall transcend. By ChatGPT. So again, what is PM&R? I work with the diagnosis and medical management of when someone says they have trouble doing fill in the blank activity. Well, what does that mean? A lot of times when you break it down, people have difficulty with muscle, bone, joint issues, aka musculoskeletal system, or they might have some neurological issues with the brain, spinal cord, or the peripheral nervous systems. So that is what I specialize in, is in the conservative management of musculoskeletal and neurological issues, and to improve function living with those. I also do care about other organ systems as well. These are just the primary areas of focus. So PM&R, in treating someone, I'd say the 3 M's: movement, motivation, and management. Here you can see a QR code. That's my professional society. If anyone is savvy with the cameras or not. This has a long, long list of a whole array of diagnoses that I can potentially touch upon with my patients. So I like to give that out a lot. So I haven't yet told you what I did, because I like to tell my patients, hold on, be patient with me. There's a lot of components to my plan. Dr. Josh Cohen was just telling me how long my notes are, because there's so many components. So let's start with this is a picture of a gym representing my close collaboration with rehabilitation therapists. That's PT, OT, and speech therapy. So I am not a rehab therapist, but I work very closely in finding the subspecialist rehab therapist, or the right one that fits the conditions that my patients have. And the picture below represents the highly multidisciplinary collaboration with the oncologic team, the medical subspecialty team, rehab therapists, the psychosocial team. All of these are important to help someone move better. These represent conservative management without medications. So the S-shaped tool there is something I recommend frequently for trigger points, also known as muscle knots. It's a self-massaging stick. I like to recommend that before injections. The other things you see there, that's a heating pad. It's a knee brace, also known as orthotics. We also work with prosthetics, artificial limbs, DME, durable medical equipment like walkers and other devices. And I am still a physician, and so I also do labs, imaging, nerve studies as needed to help with the diagnosis of the usually musculoskeletal or neurological condition. I also do prescribe medications, and I do some injections as well, usually related to pain or spasticity, which is a tightness that happens when there is injury in the brain or spinal cord. Other aspects of function that people don't usually think about are eating, swallowing, bowel function, bladder function, sexual function. More of that from Dr. Seth Cohen in a little bit, but there's pelvic floor therapy, there's cognitive rehab. So all of these things are under function, and you have muscles in these areas, not so much the brain, but there are muscles in many places that we don't typically think about. The Tetris there represents cognitive rehabilitation, cognitive abilities. So if someone has difficulty with memory or problem solving, it would be very hard for them to follow a physical therapist's recommendations. If someone is really sad, that would also affect someone's motivation. So I have a holistic approach, as you can see, just to get someone to move more. It takes a lot of different components. And the Tetris represents the fun part. If someone doesn't enjoy the movement that they're doing, they're not going to do it. And so I like to ask my patients, what do you like to do? And build their personalized physical activity plan from there. Social support is also extremely important, from the motivation level and also from the physical assistance level. Some people need physical help dressing or bathing. So knowing the social environment and the physical environment is also very important to the plans that I develop for my patients. This I like to call a Venn flower. So it represents the many different specialists that I collaborate heavily with, in particular orthopedics, neurology, and the pain subspecialist. At City of Hope, Orange County, Lennar Foundation Cancer Center, mouthful there, we also have palliative care specialists, or also known as supportive care medicine, and integrative medicine. And so we share a lot of patients to have a full multidisciplinary supportive team for the patient's quality of life and their ability to do the things that they want to do. You guys ready for another poem? So I'll let ChatGPT explain cancer prehabilitation. How many of you guys have heard about cancer prehabilitation? All right, glad I'm here again. So before the storm of treatments might, prehabilitation shines its light, preparing hearts and bodies strong to face the fight, to right the wrong. With exercise and plans in place, we build resilience, find our grace. Cancer's journey we'll undertake, prepared and strong for life's sake. I heard you. I asked it to rhyme, specifically. So, what is cancer prehabilitation? So the three major components are exercise, nutrition, and psychological health, and optimizing these things before they do their surgeries. And so I like to troubleshoot the barriers to the implementation of these programs. As you can imagine, people will say, I'm too tired to exercise, I have back pain, I have knee pain, this or that, or they're just not motivated. And so I troubleshoot those barriers with the patient. I refer to specialists like my core PT team, OT, and psychosocial team to help implement this program. And the idea is to start early, to start before the cancer treatment that may cause a change in function afterwards. And so starting in the beginning, I can follow my patient throughout the cancer journey and optimize function throughout the journey. And this has given my patients a sense of control in the setting of, oftentimes in cancer, lack of control. So cancer prehabilitation is an international phenomenon. 10 years ago, there were 6 articles on cancer prehabilitation. Now there's over 1,500 articles. And Dr. Josh Cohen and I were just scheming about creating our own study for cancer prehabilitation. So we plan to add to this. All right, so let's focus on exercise. Exercise is medicine, and I encourage my patients to move through cancer. All of these resources are available at that QR code that I give my patients, but I also print them out too. And so the 2 major components are aerobic exercise and strength training. What I like to point out here is the cancer-related fatigue. So exercise has been studied in cancer patients specifically. And oftentimes in cancer, almost everyone feels fatigued at some point. The best medicine for that fatigue is exercise. It's counterintuitive. When people are fatigued, they don't want to move. And when they don't move, they get more fatigued. And so the best evidence, the strongest evidence, is actually to break that cycle with exercise. I also want to point out lymphedema. Strength training is important in lymphedema. When there is surgical or radiation damage to lymph nodes, it can cause fluid backup and swelling in the arm for breast cancer, in the leg for gynecological cancer. And it used to be that strength training was avoided in the setting of lymphedema, but actually it's been shown to be beneficial in lymphedema. I also want to point out bone health. Oftentimes in women's cancers, there's hormone therapy, and that can decrease bone density, which can lead to a higher risk of fractures. And so strength training and exercise, among other treatments, is important to optimize bone health. So this is a very busy slide. I like to point out the word strong evidence in the middle there, and that exercise is relevant to cancer outcomes. It's not just a good thing that you don't want to do, that your mom told you to do, but it has been shown to prevent 7 common cancers, notably breast and endometrial cancer are listed there. It's also been shown to help with the survival of 3 common cancers, of which breast cancer is one of them. And before ovarian cancer survivors feel left out, I would argue that the research isn't there yet. We're going to create it. All right, so let's dive down into the micro level. This wheel represents 14 different cellular mechanisms involved in cancer. And so in the middle layer, there's pictograms of different types of exercise, and there has been evidence linking exercise and different forms of exercise to these cancer cellular mechanisms. The big check marks you see on the outside shows where the most evidence for that linkage exists currently. Now, stepping back to the macro level, the goal of cancer rehabilitation, cancer prehabilitation, is to improve function and to improve cancer outcomes. And so in this graph, you can see that the black bar represents the exercising group. The gray bar represents the sedentary group. And the exercising group was able to tolerate cancer treatment much better than the group that sat more. In the same study, they also showed that there was less pain and cardiac problems, that the exercisers had less ER visits and hospitalizations. And this all boils down to cost savings for everybody. So the summary, as I said, the goal is to optimize function. And optimize function when? It is throughout the entire cancer journey with this blue arrow, as you see. And to paraphrase Sam Golter, who is our founding father, is that right? First Lady of Hope. There's growing evidence that prehab profits curing the body, that rehab restores the soul, and we do this through maximizing function and decreasing disability. So I hope next time someone asks you what cancer rehabilitation or prehabilitation is, all your hands will be up. All righty, thank you so much for having me.
All right. Well, thanks for still being here. So my name's Seth Cohen. So survivorship. What is survivorship? I think what we've heard from our other 3 wonderful speakers, this is going towards the latter part of that journey. You've been treated for cancer, or a loved one's been treated for cancer, now, or you're still in treatment for cancer and you're looking for quality of life. So survivorship is a relatively new term. So one of the really important organizations for cancer care in the US, the NCCN, has guidelines specific to survivorship care and really to cancer-related latent long-term effects. The term cancer survivor was proposed in the 1980s, and it really was to raise awareness of outcomes and changing needs of those who have gone through cancer treatment. So who is a survivor? Someone who's starting at the time of diagnosis, during and after treatment, and really throughout the balance of life. This could be someone who has a chronic cancer process that you heard about on chronic treatment. This could be someone who's finished their radiation and their chemotherapy. This could be someone who is a little unclear where they are, but really struggling with quality of life, and we want to give that back to them. So it's not really meant to be a label. It's really meant to identify a community of people with a history of cancer or ongoing cancer, and we want to have a common term that's useful for improving the care of our survivors. So what are some survivorship care standards? It's really prevention of new and recurrent cancers. It's looking at the late effects of cancer and treatment. It's routine testing for the return of a cancer, otherwise known as surveillance. It's routine testing for new cancers, otherwise known as screening. It's the assessment and treatment of the late effects of cancer and treatment. It's coordinated care between providers. It's planning for ongoing survivorship care. It's many, many, many things. And really, it's an enhancement of quality of life through a multidisciplinary team approach. It's truly a team sport. When you look at some of the effects that people experience, it's a very, very wide catch. Hormones, hot flashes, lymphedema. You've heard all these things from my colleagues. Cognitive dysfunction, urinary incontinence, sexual dysfunction, and so forth and so forth. And who are the team members? Well, cancer rehab. Dr. Jessica Chang. Dermatologists, plastic surgeons, urogynecologists, urologists, pain specialists, psychiatrists, psychologists, nutritionists, stoma nurses, everybody working together to enhance the quality of life, this part of the journey for someone that's been through cancer treatment. And there's also support for caregivers as well. What are some general recommendations? And you've heard this alluded to by Dr. Tseng earlier. Quit smoking. If you're a survivor, we want you to quit smoking. Cut down on alcohol consumption. Eat a balanced diet, plant-based, 5 to 9 servings of fruit and vegetables daily, foods low in salt and fat. Mediterranean diet's a good way to go. Account for certain individual disease states. Of course, that will be necessary based on who the person is and what their survivorship state is. Exercise, stay active. Try for about 30 minutes a day if you can. It's hard for me, but strive for that. That's a goal. We set goals high. I want to talk a little bit more about survivorship care in terms of the pelvic floor, because that's my area of expertise. The pelvic floor is not something you're going to talk about at Kiddush, right? It's not something you're going to say, oh, gosh, you got to go get a new pad. You're not going to talk about that, right? But in general, it's so important to the day-to-day function of being a human being. And gosh, does this take a hit in cancer care. This is something that really gets wrecked for a lot of people for a lot of reasons, surgeries, chemotherapies. What do we mean by pelvic floor? We mean the bladder and the bowels. Peeing, right? We'll say that word. The fancy way of saying that is voiding, going to the restroom, right? These are functions that if you can't do well, you're going to be a non-starter as far as living the type of life you want to lead. And there's a few different ways this can happen. Someone can have urgency and frequency and urgency incontinence. Someone can have stress incontinence, and someone can have pelvic organ prolapse. This is veering towards the female or woman's side of things, and so that's what we're going to focus on for the moment. There's, of course, a male side of things, but we could take up hours with this conversation. So the bladder. This is, if you're taking the test on the bladder, I just gave you the crib sheet. This is all you need to know. The bladder needs to store urine. It needs to empty urine. It's an innervated muscle. There's 2 sphincters, or essentially 2 places where you try to prevent leakage, and nerves matter. Neuropathy matters. If you have diabetes, if you have Parkinson's, if you have a spinal cord injury, if you have had a stroke, this all dramatically also impacts your bladder function. Stress incontinence and urgency incontinence are really the 2 main ways people leak. What is stress incontinence? Oh, gosh darn it. That's stress incontinence, right? What's urgency incontinence? I gotta go to, oh, gosh damn. You didn't make it. You had an urgency to go and you just didn't have the time to get there. What are these phenomenon? Stress incontinence has to do with the urethra. It's the little tube that empties your bladder into the outside world. And so when there's not enough ligamentous support of that urethra, when you bear down or lift groceries from Trader Joe's or cough or sneeze, that urine comes out and that urethra is gaping open. The urgency incontinence, the bladder is a muscle. That's where that bladder muscle is spasming. It's spasming and literally just spitting urine out. And there's lots of different ways this can happen. This happens just to people without a cancer history, and we certainly treat those patients. And this certainly happens to people with a cancer history, because of radiation and the surgery they've gone through and the systemic treatments that Dr. Tsang and Dr. Cohen have given them to save their lives. But now that their lives are saved, you've got to preserve the quality of their life and enhance the quality of their life. So if someone comes into my office, happened today, and says, I'm having one of those oopsie moments where I feel like I need to go to the bathroom and I can't make it, what are we looking for? Well, we want to make sure there's no infection. We check for blood in the urine. What are some general recommendations? Coffees and teas, not your friend. Herbals, chais. So many people tell me, I say, listen, just cut down on the coffee. But I only drink 2 or 3 cups a day. That's a lot. Just don't drink the freaking coffee if you're trying not to go. Bubbly, LaCroix. Try to go to the bathroom on a schedule. Set your fancy Apple Watch, your iPhone to go to the bathroom every 2 hours, even if you don't feel like you need to go. Try not to drink fluids for 2 to 3 hours before you go to sleep. Your well-meaning primary care physicians, if they're giving you hydrochlorothiazide or Lasix or some medications that are making you go to the bathroom to pee, try not to do that after 8 p.m. Ask them, hey, Dr. Smith, can I take that medication in the morning? Try not to take that medication at night. We have some really fancy medications, even ones that have come out in the last 2 years, that can work on those bladder muscle receptors to reduce bladder muscle spasms, and some of them can be very effective, and those are possibilities. And then, of course, there's pelvic floor physical therapy, which we alluded to earlier with Dr. Chang, and I'll go into that a little bit more shortly. There's fancy treatments. What are the fancy treatments? These are really impressive therapies. There's bladder Botox. So no, not just for your face, for the bladder as well. The bladder has wrinkles. I bet you didn't know that. And so we can inject Botox into the bladder muscle and partially paralyze the bladder muscle to reduce spasms. Believe it or not, there's pacemakers for the heart. There's a pacemaker for the bladder called sacral neuromodulation. No joke, it's very impressive. And so we place that little pacemaker device into the buttocks area and actually direct it towards the nerves that are coming out of the sacrum that go to the bladder. And there's even acupuncture for the bladder as well, called tibial nerve stimulation. That's going to become very fancy because we're going to actually be able to implant something into your ankle in the next 1 to 2 years that will stimulate nerves that go to your bladder and reduce your urgency and frequency. Let's switch gears to stress incontinence. So poison pressant inserts, some people can go home tonight and order this on walmart.com if they want, or target.com. These are inserts, vaginal inserts that support the urethra to reduce leakage with coughing, sneezing, and laughing. They're essentially tampon-like inserts specifically developed for stress urinary incontinence. They're not the answer for everybody, but certainly for the right patient, they can make a difference. There is little fillers for the urethra. Once again, fillers for wrinkles exist. There's a filler for the urethra where we can look in the urethra of the camera and inject a medication into the urethra to thicken the urethra, kind of like tightening the washer on a faucet so you don't leak as much. That's less than an hour of an operation. You go home the same day. You may have a big difference in your quality of life. Unfortunately, that doesn't necessarily last very long, maybe a year or two of benefit, but for the right person, it can make a big difference. There's things called slings. Maybe you've heard this. You know, you're at the mahjong table and someone says, I got my sling. I'm not leaking anymore. It's a miracle. So slings can be made from a few different materials, mesh, synthetic material, or believe it or not, a tendon. So we can make an incision on your thigh and take a strip of the tendon from your thigh and transfer that underneath the urethra so the urethra has a new buttress or support so you don't leak with coughing, sneezing, laughing, moving. That's very important for our cancer survivorship patients. We try not to put too many foreign body materials in their tissues because their tissues have been through so much already. And so the ability to use their own native tissue is very important for a lot of the care we deliver. And pelvic floor physical therapy, which we're going to come to in a moment. This is a picture of the bulking agent, that little filler for the urethra. This is a picture of what those slings look like, placed underneath the urethra to support the urethra. A brief discussion about pelvic organ prolapse. What is pelvic organ prolapse? It is otherwise known as vaginal prolapse, or otherwise known as a hernia of the pelvic floor. When someone talks about these fancy words, what is pelvic organ prolapse? It's really a hernia of the pelvic floor. It's a weakness in the ligaments of the pelvic floor that allow the organs to descend down. So what does that translate into for the experience of the patient? A bulge or pressure sensation in the vagina, a feeling like you're delivering a baby again when you're probably at a point in your life where you don't think you should be delivering a baby, a sense that you need to push the vaginal tissues back inside with your hands to poop or to pee, to get the urine out or to get poop out, pain with intercourse, personal relations. These are all sensations that can occur with pelvic organ prolapse that can be very, very life-limiting. In some of the worst instances, and I've seen some pretty bad instances, bleeding, pain, excoriation of the tissues, really significant stuff. There's something called a pessary, and there's a picture of that on the right side of the screen. It's a little silicone ring that can be placed into the vaginal canal to support the vaginal wall tissues. And so some of our friends in our mature homes will come in from those facilities for their pessary changes, and we take that little silicone ring out, we wash it, we put it back in, and they're good to go for another 4 to 6 months. And then there's surgeries. And once again, we could spend a lot of time talking about surgeries for this, but the surgeries are very effective for helping with this quality of life deficit, suffered by cancer survivorship patients, but certainly by patients that have not been treated for cancer as well. Pelvic floor physical therapy, and we're finishing up here. It's not just Kegels. It's more than Kegels. I have so many patients that walk in the door and say, have you ever thought about doing pelvic floor physical therapy? I already do my Kegels, Dr. Cohen. I do them. It's not just Kegels, right? For instance, there's some fancy descriptions. The pelvic brace, the pelvic tilt, the deep squat, the lateral lunge, the inner thigh squeeze, bridge with knee taps. I wish I could have gotten a better picture of that one. Clamshell, and the prone diamond, perhaps the jewel on the screen here, the prone diamond. We're going to look that up later, Dr. Chang, so we can show it to our patients. I would tell you that whatever you're thinking about pelvic floor physical therapy, rethink it, because there is a whole world of therapy waiting for you with the right provider. You have to see someone that knows what they're doing, that is engaged with pelvic floor physical therapy. It is not musculoskeletal physical therapy. You know, most physical therapy facilities will tell you, oh, we have someone that can do that. We have someone that can do that. And they don't, right? They have someone who's well-meaning, that's, read a few things on Google or ChatGPT. So I'd encourage you to find a center that has someone who is experienced in pelvic floor physical therapy to really get the benefit of that intervention if you're going to spend the time doing it. Because once again, for the right patient, it can make a very significant difference. These are just some resources for pelvic floor physical therapy. There's various societies that have websites with information. There's even something called Hinge Health. Hinge Health is unique. It's a home-based physical therapy. And they've actually put a lot of effort into developing their pelvic floor physical therapy component. So if you don't want to leave your home, there's even something you can do virtually now, believe it or not. But once again, I think the important point is find a qualified pelvic floor physical therapy therapist in your neighborhood and region. We certainly have that at City of Hope Orange County, and there's other centers. There's a few centers in Orange County. There's not a plethora, but there's a few. Thank you very much.
Thank you all so much for those wonderful presentations. I really learned so much. So we want to open it up now to questions. So if you have a question, if you want to raise your hand, and I will come around with this other microphone that hopefully works, and you can present your question, and then we'll decide who should answer it. Okay? All right. Hello? Oh, good. Works. Okay. Does anyone have any questions?
I understand for the women, but as a guy, what is the percentage for men with breast cancer? Because you never hear about it. It's not ever talked about. But I do know that it's out there, and men don't even think about it because it's not what's publicized is the word I'll use. What percentage of men are being screened and shown to have male breast cancer?
Thank you. So the highest risk men are those who have the BRCA1 gene, personally. And so their risk is actually 7% over the course of their lifetime. So you can compare that to a woman with BRCA, where 80% lifetime risk. So 7% is actually a risk that's lower than the population risk for a general average at-risk woman. 1 in 8 women in the US get breast cancer, 12% lifetime risk. So a male with the highest risk gene mutation BRCA is 7%. So this is why you don't hear about routine screening in men. However, this population, we do highly encourage considering imaging. Even though we talk about genetic mutations, a couple of us have, we know genetic mutations all afflict families differently. Some are much more penetrant, which means that there are many more family members who have cancer with the genetic mutation in that family than others then too. So this is one of those guidelines that is malleable. We recommend annual exams for men who have BRCA1 or 2 mutations. It's usually BRCA2, and then thinking about considering an annual mammogram too.
I'll ask one more question. Go with that then. What percentage of men actually get testing for the BRCA gene? I mean, I did it because my mother had breast cancer, and I wanted to know for my daughters. It's not talked about.
No.
Nobody talks about men going to get tested for that gene.
Yeah. We hope we do here at City of Hope. So Dr. Cohen alluded to this. We have a really robust genetics program. And anyone who tests positive for a mutation, their family members are eligible for cascade testing. So free genetic testing within 6 months of their testing result. And we even have a clinical trial at City of Hope, Dr. Cohen was alluding to, where you can get genetic testing as part of the clinical trial, even if you're outside of that window as well. That is a common thing that is missed, where male family members aren't tested. So I really commend you for pointing out that really important fact too.
I asked them therefore, insurance. How many people are worried that if they get tested, it's going to go through the insurance company, and that all the things afterwards are going to follow them down the road in regards to insurance being taken care of?
Yeah, this is a big problem in genetics right now. There actually aren't great legal protections for some of these issues. I think Dr. Cohen faces this as well with his family members.
Yeah, I can, and this. Thank you for bringing this up. So I do want to say again, if you have Ashkenazi Jewish, heritage, you should get genetic testing, and the insurance will cover that. I also want to say the reverse side of it. If you have a male family member who does have breast cancer, they should definitely get genetic testing because it is so rare that there's a reasonable chance they may have a mutation. So anyone in the family, if you have an uncle or a male cousin, or you hear someone who had breast cancer, very concerning that that's a BRCA mutation carrier or another mutation, because male breast cancer, as you heard, is so rare in general. So if they do not have a diagnosis or have not had genetic testing and they have breast cancer, they should get tested. If they do not want to get tested, their family members should get tested. From an insurance standpoint, there are some basic protections for insurance. So with the Affordable Care Act, and there are pluses and minuses to that, legally an insurance company cannot discriminate and not offer you genetic or insurance because of your history of genetic testing if you do test positive. There are not protections as far as the rate, so the rate may be up a little bit. I would argue that it's more important to know that information than it is the increase in the rate for the insurance. The challenge that does come up is life insurance, and I think this is an honest question you have to ask yourself as a person and within your family. If you do test positive for BRCA mutation, it's also like anything. When you apply for a life insurance policy, they look, do you have diabetes? Do you have a congestive heart failure? And if you have these, your rate does go up. So if you know you have a genetic predisposition to cancer, any insurer who does life insurance probably will use that when they calculate the cost of your insurance. This is a personal decision you have to make for yourself and your family. I would still argue, depending on who you are, I would much more so advocate that information is still important to have as a family member for you and your family, knowing that rate may go up. But I completely want to validate your concerns, and it is out there. I think this is also a chance for all of us as consumers here in the U.S. to advocate for our politicians to do better with insurance coverage and change that. I know it's a bigger question we're not going to answer tonight, but I would implore you to still do the testing. There are protections. You will be able to get medical insurance. The rates may be impacted, but we have many ways to help with that too. We're really good at writing letters as physicians to advocate for you.
Thank you, and that's a really important question, and it's one of the goals of Sharsheret actually, is to spread the word to men about the importance of them being tested. We actually have a pamphlet that's out on the table out there that was designed specifically for men, so you can take a look at that when you.
I paid the money, so it would never show up on I actually paid out cash, so
For a male BRCA1 carrier, how old should they start their screening?
If they know they're BRCA1 positive or BRCA2 positive,
One.
BRCA1, I would say each third year later. I'm not sure if Dr. Singh has a take on that, but I wouldn't start before that. I think also if they have, the family history would be important. So if they have a family history of pancreatic cancer that's younger in onset or other cancers, we still want to know that. And the teaching is to still start about 10 years earlier than the youngest person who's diagnosed with cancer in the family, depending on what they're at. And for men, there's also linkage of BRCA to prostate cancer as well. So I think so. If someone is absolutely identified as a BRCA man, they should be aware of prostate cancer screening as well, because that risk has been shown to be unfortunately occurring. I'm not so sure if it's definitive one versus the other. I'd have to verify, to be honest with you, but certainly more common in BRCA2, but I think either one would warrant screening.
Colorectal, skin
Any other questions?
Thank you. One of you addressed the issue of lymphedema and the possibility of rerouting stuff during surgery. Is there anything to be done after the fact? Surgery's already happened a couple of years ago. Is there any way to fix that now?
Lymphedema is a whole other field that it's really a specialty of the plastic and reconstructive surgeons. The lymphovenous bypass that I mentioned is actually historically a treatment of lymphedema. So it actually does work to help reduce lymphedema in someone who's already experiencing it. Other techniques are lymph node transfers as well, really transferring fresh lymphatic tissue into an area that's compromised. Oftentimes this is done by surgeons who are experienced, have extra training in transfer of tissue. So it needs to be at a center where there's a high volume microvascular surgeon. So what we're doing these days is trying to prevent, hopefully, lymphedema from happening by doing these bypasses in advance. But historically, these are actually reactionary procedures too. So these same procedures can work very effectively for someone experiencing this complication. So, and I'll let Dr. Chang talk about it, because lymphedema is not just surgery. There's a lot of other things we can do to help.
Yeah, so the gold standard for lymphedema care is lymphedema therapy. It can be very involved with compression, bandaging, exercise, skin care, manual lymphatic drainage. And so lymphedema surgeons typically want to see that the maximal effort and good adherence with this very involved lymphedema therapy was done first, to show that when they do the surgery, that the lymphedema therapy will continue and they will have a good surgical outcome. So it's also a collaboration between rehabilitation and lymphedema surgeon.
Yeah, I think quality of life is paramount, and this is where maybe making your way to, or your loved one, to a comprehensive cancer center that has a physical medicine rehabilitation expert, physical therapist that specialize in lymphedema massage and wraps can make a big difference. There are also some different devices that can be used at home depending on how significant the lymphedema is to improve quality of life. But you're not going to hear about this unless you seek out specialized care. So I think this is something where your primary care doctor can play a role by putting in a referral, or again by seeking a comprehensive cancer center where they have specialists who work with patients with lymphedema.
Any other questions? Okay.
Why is there so few physical therapy doctors out there like you? My wife had lung cancer 10 years ago, and the only two people who got her through it are the two people you're looking at. There was nothing out there to help us navigate through this whole process. Why are there not more? Why is this not being spread? It sounds like there's very few in Orange County. Why?
I'm very sorry to hear that, first of all, and this is not an uncommon story that I hear from my patients. And so this is a relatively new field within physical medicine and rehabilitation, and it's actually the fastest growing subspecialty field within the larger PM&R field. And so I think you guys are part of that. Let's spread the word of cancer rehabilitation medicine, or PM&R. Yeah, that's what I can say. The word is getting out there, but it needs to get out there a lot more. There's maybe like 40, 50 some subspecialists in the nation. 3 in Southern California, 1-ish in Northern California, maybe around 5 or 6 in the West Coast.
Yeah, and I'll just add that I think what you're hitting on too is going back to the survivorship part of this journey, is where this is a completely new set of knowledge that's evolving and crystallizing, of which cancer rehabilitation will be part and parcel to that, both in the prehabilitation state, but certainly in the survivorship state as well. And so what's exciting is we have more survivorship from the efforts of our oncologists and cancer physicians. People are making it longer. They're living longer. Thank goodness, thank God. And so we have the opportunities now to really focus on quality of life and getting them through the rest of that journey. Their journey doesn't stop when the chemotherapy stops or the surgery's been halted. So there's still more to do and more we can help with.
One or two more questions.
Actually, mine's more of just a comment for physical medicine and rehab. I think where the switch is starting to happen now is the prehabilitation care, where we're looking at before the struggles begin, how can we rehab before the treatments happen? Because then you start to understand the road ahead of you, and it makes the travels a little bit easier. I'm in rehab.
Thank you. Yeah.
This is one of the more common aspects so I do a lot of lymph node surgery as a breast cancer surgeon. And so under Dr. Chang's sort of oversight as well, our patients actually see occupational therapy for lymphedema prevention before surgery. And then they're followed consistently throughout their postoperative recovery too. This program has been shown to be quite beneficial. We have incredibly low lymphedema rates because of that very aspect too, where we're getting ahead of it. We're prehabbing, not just rehabbing.
I was just curious if you would share your chat GPT poems.
Of course. I don't know if I need ChatGPT's permission. But I just wanted to shout out to Dr. Singh. She was presenting this weekend on, was it axillary reverse mapping technique that she does that decreases lymphedema therapy, decreases lymphatic damage in surgery dramatically. So it decreases the lymphedema rates dramatically. So that was something new to me that I was very pleased to find out.
And I think what you're hearing from everybody, including our wonderful audience that's still here with us, is to continue to advocate for yourself. That I think the care is out there, and I think one of the reasons that we all came here is to provide that level of care. So, seek this out for your loved ones. Just know that it is getting better, and it's okay to get another opinion if perhaps you're not hearing some of these things with the first doctor you meet. It's okay.
Oh, sorry.
I would like to say that I have lymphedema, but it's definitely under control with exercise. I really stress that, to really exercise. I'm also a survivor. I was diagnosed 27 years ago, and I've always exercised for the past 60 years.
and I think that's helped me get through, although it has metastasized to stage 4 after 14 years. And so for the past 12 years, I've been under many different medications. I've also been to many different hospitals and doctor care throughout Los Angeles, and I've been in City of Hope in Duarte with Dr. Waisman, who I thought was fantastic. Unfortunately, he's retired. And for the past year, I've been at City of Hope in Irvine, and the service there, the people there, I cannot tell you the difference from all of these other hospitals that I have been at. It is so great. You feel very special, very cared for, and from everyone that you meet within the hospital, there's a positive, caring concern for the patients.
Thank you.
Thank you so much. Unless anyone has any other comments that they want to make.
I just wanted to say I'm so happy to hear your story, and congratulations for your survivorship and doing so well through everything. Yeah. Yes.
God willing. God willing. Great job, exercise. Yes. Yes. The Our hope is to limit driving. 20% of people were leaving Orange County for this type of care, and we're hoping at least those 20% no longer have to leave, that they can stay here and not have to go to LA for this type of care.
You go where you have to go to get the best doctor.
Absolutely.
Which is why we got you guys.
That's right. Yeah, I just want to say thank you all for sticking around and being here. And it's been our true pleasure and honor to be here with Sharsheret. Thank you so much. And Congregation B'nai Israel for welcoming us, and Rabbi Adam Greenwald for being our host and letting us be here. And all of you, our experience is richer for your participation and your questions and learning from you as well. So it's absolutely an exchange, and thank you for sharing stories and being, we're all in this together. So appreciate it.
Yeah, and I just want to say thank you to our esteemed doctors who came out tonight to teach us, and so that we can be more educated and take better care of ourselves. And I want to thank all of you for coming, and I want to remind you that Sharsheret is here for you. And if you know anyone that needs support, we're here. And you can actually get my card, which is on the table in the front, and refer people directly to me. So thank you again for being here. All right.